This is Dr. Mimi Lamb from Case Western Reserve University in Cleveland, Ohio, and I would like to explain to you the basic types of renal replacement therapy, or RRT, that are most commonly used in the intensive care unit. In this overview, we'll be talking about three modalities of RRT: hemodialysis, continuous veno-venous hemofiltration, or CVVH, and continuous veno-venous hemodiafiltration, or CVVHDF. So let's start with some basic terms that describe the mechanisms by which fluid and solute can be transported with renal replacement therapy. Diffusion is the movement of a solute across a semi-permeable membrane down its concentration gradient. Ultrafiltration is the movement of plasma water across a semi-permeable membrane driven by a pressure gradient across the membrane. You apply a negative pressure on the other side of the membrane and pull plasma and everything that is dissolved in it through the membrane pores. Convection is the movement of solute dissolved in plasma across a semi-permeable membrane. As the plasma is ultrafiltered, the dissolved solute is carried along by convection or solvent drag. With hemodialysis, the patient's blood is circulated past a semi-permeable membrane with the patient's blood on one side and dialysate solution on the other side. The membrane contains many tiny pores which hold back larger elements like blood cells and proteins, but allow small molecules to pass through the pores. Plasma composition is altered by diffusion of molecules down their concentration gradients to or from the dialysate solution. The dialysate contains low to zero concentrations of solute that are to be removed, like potassium, BUN, and creatinine, and higher than normal concentrations of substances that are to be added to the plasma, such as bicarbonate. Solutes that do not need to change much in concentration during dialysis, like sodium and calcium, are present in the dialysate at normal physiologic concentrations. So this is how blood is cleaned during hemodialysis. In this diagram, here's the patient's plasma volume in this box. The blue circles represent water, and the red are bad stuff like BUN, creatinine, and anything else you need to get rid of. So as dialysate flows past the plasma on the other side of the membrane, it picks up the bad stuff, which moves through the tiny pores down its concentration gradients. The dialysate is then discarded, leaving lower concentrations of toxins, and that's how the blood is cleaned. But patients with renal failure are also often volume overloaded because their kidneys are unable to get rid of fluid. So plasma volume in these patients can be decreased by ultrafiltration. Here you start with your volume, the water and the toxins, and by applying a negative pressure across the dialysis membrane, you suck out plasma by the process of ultrafiltration and all the molecules dissolved in it by convection, leaving you with a smaller volume, but no change in solute concentration. Although the very first dialysis membranes were flat and about the size of a coffee table, current dialyzers achieve more surface area in a compact space by being made in the form of capillary-like hollow fibers with fenestrations along their entire length, about 10,000 of them in a single dialysis cartridge. The patient's blood flows through the capillaries, and dialysate solution flows past the outsides of the fibers and runs down the drain, carrying the molecules that diffuse from the plasma along with any ultrafiltrate that gets pulled out. So let's summarize what we accomplish with hemodialysis. Blood is circulated through semi-permeable capillaries surrounded by dialysate solution on the outside. Plasma composition is altered by diffusion, and plasma volume is decreased by ultrafiltration, so the blood is both cleaned and reduced in volume. Ultrafiltration typically occurs at a rate of about 1 to 2 liters per hour, and the usual dialysis session lasts between 2 and 4 hours. So this means that a patient can lose 2 to 3 or more liters of fluid in a single dialysis session, which is an amount roughly equal to their entire plasma volume. Plasma volume in a 70 kilogram person, for instance, is about 3.5 liters. So one of the difficult issues with hemodialysis is that the amount of intravascular fluid removed has to be replaced by vascular refilling from the interstitial and intracellular fluid compartments. In other words, if you remove 3 liters of fluid with dialysis, that has to be replaced in the person's vascular space by 3 liters or close to it, seeping in from the interstitium, the fluid that surrounds and bathes all cells. And if that doesn't happen, or if the patient can't tolerate the transient negative intravascular fluid balance while waiting for vascular refilling to occur, they can become seriously hypotensive and hemodynamically unstable. And so in 1977, continuous renal replacement therapy, or CRRT, was first developed, which essentially spread the procedure of dialysis over 24 hours instead of doing it all in 4. Since then, CRRT has become the mainstay in the management of acutely ill, hemodynamically unstable patients with acute or chronic kidney injury. Today, the main methods of CRRT that we use are CVVH and CVVHDF, and we'll look at a brief description of each. In continuous veno-venous hemofiltration, or CVVH, venous blood is circulated at a slow rate through a hemofilter consisting of thousands of semi-permeable capillaries, just like a dialyzer but smaller. Negative external pressure can be used to create a gradient across the capillary membrane that allows large volumes of plasma to be ultrafiltered and removed, dragging solute with them. But unlike with hemodialysis, the ultrafiltered plasma water, which contains all its usual small solutes, such as sodium, creatinine, urea, and calcium, is simultaneously replaced IV by a fluid similar to dialysate. So over the course of hours to days, many liters of uremic plasma water are gradually removed by ultrafiltration and replaced with toxin-free solution, and so the blood is cleaned. Meanwhile, volume can be altered by the amount of replacement fluid given. If the patient can't tolerate any decrease in intravascular volume, you replace fluid as fast as you ultrafilter it, so there's no net fluid loss. But if the person can tolerate a little fluid removal, you can remove a liter of plasma and give 990 cc's of replacement fluid back, a negative balance of 10 cc's, or 950, etc., resulting in a slow decrease in intravascular volume. Thus, solute and fluid balance are altered slowly and smoothly by a combination of ultrafiltration, convection, and replacement. Also, convection can remove larger molecules than diffusion can. So with hemodialysis and diffusion, only very small molecules, such as creatinine, molecular weight 113, urea 62, sodium 23, etc., can be efficiently removed. In CVVH, the use of convection allows the so-called middle molecules, molecular weight 500 to 60,000, to be removed as they are dragged through the semi-permeable membrane along with water. In continuous veno-venous hemodiafiltration, or CVVHDF, ultrafiltration and replacement of fluid occurs as we just described, similar to CVVH, but the hemofilter is also exposed to dialysate, which allows a few more molecules of urea, creatinine, and so on to be lost by diffusion, so that plasma composition and volume are altered by a combination of ultrafiltration, convection, and diffusion. Schematically, here's how CVVH looks. We start with our volume of water and bad stuff, and by ultrafiltration, we remove huge amounts of plasma and all that it contains, so that we could potentially end up with a much smaller volume. But now we replace the lost volume, almost cc for cc, with toxin-free replacement fluid, so that after equilibration, we end up with the same volume, or maybe a little less, but much lower concentrations of bad stuff. And with CVVHDF, we do the same, cleaning the blood with a combination of ultrafiltration and replacement, just like on the last slide, but we also have dialysate trickling through the cartridge outside the capillaries so that a few more molecules of urea, etc., can be lost by diffusion in addition to the large amounts already dragged out with ultrafiltration. So let's look at the setup for each of these three procedures. In hemodialysis, the patient's blood flows through the hollow fiber dialyzer. Dialysate flows through the dialyzer cartridge, bathing the capillaries with metabolic waste products diffusing out of the plasma into the dialysate, which is then discarded down the drain. Remember that ultrafiltration can also be employed by adding negative pressure to the airtight dialysis cartridge and pulling plasma through the capillary pores to reduce intravascular volume. Hemodialysis is typically performed in sessions that last 2 to 4 hours. Here's a dialyzer machine in action, and you can see the patient's blood flowing through the dialyzer cartridge, its rate controlled by a roller pump at 300 mL per minute. The dialysate, which is continuously made by mixing concentrated components with deionized water from large tanks behind the machine, flows through the dialyzer cartridge, bathing the capillaries and carrying away dialyzed toxins, which are then discarded into the drain after a single pass. The screen at the top of the dialysis machine shows data like the patient's most recent vital signs and the amount of ultrafiltrate to be removed during the session. Here, 3,200 mL at a rate of 670 per hour, with 2070 already being removed. And if you watch this figure, you can see it increase 1 ml at a time as ultrafiltered plasma is pulled out through the dialyzer capillaries. You can also see the patient's blood flow rate of 400 mL per minute, the dialysate flow rate of 800 per minute, the amount of time left in the dialysis session, which is the white part on this pie chart, or an hour and 37 minutes out of 4 hours. Note that with both dialysis and CVVH, when a dual lumen catheter is used for access, the entering and exiting blood lines are actually both venous blood. They're labeled arterial and venous, only so that we can keep track of which one is leaving the patient and which one is entering. The pressures within the two lines are carefully monitored to be sure that they stay within safe limits. The pressure in the line that is leaving the patient is negative because the roller pump is pulling blood out, and in the line returning to the patient, the pressure is positive because the pump is pushing blood back into the patient's vein. In CVVH, the patient's blood again flows through a hollow fiber hemofilter, which is similar to a dialysis cartridge but smaller, since the blood flows needed for this 24-hour procedure are lower than those needed for a 4-hour dialysis. The ultrafiltered plasma is collected in large bags and measured, and is replaced with dialysate-like replacement fluid, which can be infused into the blood circuit either before or after the filter, or both. Remember that the patient's volume is altered simply by adjusting the balance between the volume of fluid pulled off by ultrafiltration and the volume added back as replacement fluid. The second type of CRRT commonly used in the ICU is CVVHDF, or continuous veno-venous hemodiafiltration, which is simply a combination of CVVH and dialysis. Here the patient's blood passes through the hemofilter and large amounts of ultrafiltrate are removed and then replaced with creatinine and urea-free replacement fluid. But now the blood in the hemofilter also is exposed to dialysate, which enhances solute removal by using diffusion in addition to the convection that is already happening with CVVH. So what is this replacement fluid that we use in the continuous therapies? It's essentially the same as dialysate, containing little or none of the solutes to be removed from the patient's blood, like creatinine, urea, phosphate, and potassium, larger amounts of solutes to be added from the fluid to the patient's blood, such as bicarbonate, and normal concentrations of solutes that usually do not change much during dialysis or CVVH, such as sodium chloride and calcium. And of course, there are no proteins or big molecules because those were never removed by ultrafiltration in the first place. The big question about replacement fluid is, where in the circuit should it be infused, before or after the hemofilter? Post-filter makes intuitive sense so that uremic fluid can be removed by ultrafiltration and then immediately be replaced with toxin-free fluid. But the problem with post-filter replacement is that pulling off large amounts of fluid by ultrafiltration increases the hematocrit and protein concentration of the remaining blood, leading to clogging of the hemofilter pores. On the other hand, infusing replacement fluid before the filter keeps the plasma dilute so that the filter pores don't clog, which of course decreases the efficiency of solute removal by the filter. But you really need a fair amount of pre-filter replacement because the volume of ultrafiltration is so large that the blood cells would sludge up in the fibers without it. So in most systems, you end up putting a larger proportion of replacement fluid in pre-filter rather than post. Here's how a CVVH machine looks. Again, we have the patient's blood running through the hemofilter with the rate controlled by a roller pump. Ultrafiltrate is collected in one bag. Notice it has a little yellow tinge to it because it's plasma that's being ultrafiltered. And then we have replacement fluid being infused both before the filter and after the filter, and dialysate as well. And there's a diagram here at the top of the machine that reminds us what's happening. So in this diagram, you can see the hemofilter with the blood running through it at a rate of 200 mL per minute, controlled by the roller pump. And the effluent is removed as plasma, which goes into that yellow bag. There is replacement fluid being instilled before the filter and also after the filter. And then there is dialysate running through the filter cartridge to take away a few more molecules of bad stuff. Here's a close-up of the filter and the roller pump. And notice that there are 4 different wheels that are needed to control the rates of flow for the different parts of the process: blood flow, replacement fluid flow, dialysate flow, and ultrafiltration out of the plasma. And here's the way it looks in action with the hemofilter working and the various blood pumps doing their thing, ultrafiltrate being collected in the yellow bag, and the various bags of replacement fluid and dialysate fluid instilling their portions into the circuit. The standard formula that we use for deciding how much ultrafiltrate needs to be pulled out of the patient in order to get their blood clean enough is usually about 25 mLs per kilo per hour. And this is called the effluent dose, the rate at which ultrafiltrate is pulled out. Now notice here that you have a prescribed and a delivered dose, and neither one is exactly 25 mLs per kilo per hour. And the reason for that is that there are all kinds of other ins and outs for each patient in addition to what's happening with the CVVH. So it's up to the nurses to meticulously record each of these, such as the intake of pressors, propofol, antibiotics, tube feeds, etc., and the output of urine, surgical drains, chest tubes, etc. Then the machine uses all of this data every hour to recalculate for the coming hour how much negative pressure needs to be applied to the hemofilter to create that ultrafiltrate of 25 mLs per kg per hour. Vascular access is either via a temporary or a tunneled central venous dual lumen dialysis catheter. As with most central venous lines, either the internal jugular with the catheter tip in the superior vena cava or the right atrium, or the femoral vein is used. The blood flow rate is controlled by a roller pump, so the central vein needs to be able to supply up to 400 mL per minute of blood flow. Here's a dual lumen catheter, which is essentially two catheters placed side by side and fused, each with its own lumen at the tip and each with its own side pores, allowing for better blood flow. The reason they are labeled red and blue is not that they are arterial and venous blood, because they are both venous, but so that we know which one is leaving the patient and which one is returning. This is so that you can be sure to give things like antibiotics, pressors, EPO, and transfusions into the line that is going directly back to the patient and not the line that will go to the dialyzer and have stuff removed. Anticoagulation may be needed to prevent clotting within the tiny capillary fibers of the hemofilter. Most of the time, periodic saline flushes are used to prevent clotting. Sometimes the patient is on heparin for something like a pulmonary embolus, so we can take advantage of that. Otherwise, if clotting is an issue, regional anticoagulation with citrate can be used. With this technique, citrate is infused into the blood circuit before the hemofilter. It complexes with calcium, interfering with the normal coagulation cascade as blood travels through the capillaries. In order to avoid anticoagulation in the patient's circulatory system, calcium is infused just before the hemofiltered blood returns to the patient, so that serum calcium is normalized and coagulation works. So to summarize, citrate is given pre-filter and complexes with calcium, impairing coagulation within the filter. Calcium is given post-filter and restores normal coagulation before the blood returns to the patient. In other words, only the hemofilter is anticoagulated. The patient's blood clots normally. Meanwhile, calcium citrate complexes that are formed are cleared in the ultrafiltrate and are also metabolized by the patient's liver and muscles. Things that can potentially go wrong with this complicated process include metabolic acidosis, if citrate metabolism is impaired, for instance because of liver disease, so that citric acid accumulates. Metabolic alkalosis can happen if the rate of citrate infusion in the circuit is too high, because citrate is metabolized to bicarbonate. And you can get low ionized calcium levels if the citrate infusion rate is too high or the calcium infusion rate is too low. So both citrate and calcium levels have to be monitored frequently, and their infusion rates have to be adjusted as needed. So let's summarize and compare the three different modalities of RRT that are most commonly used. And remember that with hemodialysis, you move solute and fluid by diffusion and ultrafiltration. With CVVH, you use ultrafiltration and convection, and with CVVHDF, use ultrafiltration, convection, and diffusion. Notice that the blood flow rates in the continuous therapies are lower than with hemodialysis because these ones run over a much longer period. The dialysate flow rates are also much lower with CVVHDF than with hemodialysis, because again, this is a 24/7 therapy and this one is done in 4 hours. The amount of ultrafiltrate that can be removed per hour is usually 1 to 2 liters at the most per hour with hemodialysis, and the treatments last 2 to 4 hours. With CVVH and CVVHDF, you can remove more ultrafiltrate and do it all day long, up to 70 liters per day, because you replace the volume that is lost with almost nearly as much in form of replacement fluid. Whereas with hemodialysis, you don't get a chance to replace anything. Notice that the net fluid removal for all three therapies can be about the same, 0 to 4 liters per 24 hours, except with hemodialysis, you do it all at once. And with the continuous therapies, you stretch it out over 24 hours, which is much easier on the hemodynamically unstable patient. Now here are 3 little variations on the continuous therapies, and you'll probably hear people talk about them, but don't get confused or panicky. Just think of intermittent hemodialysis as being at one end of the dialysis spectrum, 4 hours per treatment, maximum efficiency, and CVVHDF being at the other end, 24/7 treatment, very slow but best tolerated. So here they are, and you may encounter them in different hospitals, different ICUs, and if you forget the acronyms, you can always look them up on your phone. So we have PERT, or prolonged intermittent renal replacement therapy. This is essentially a 4-hour dialysis stretched out to 6 or 8 or 10 hours for patients who can't tolerate a regular 4-hour dialysis but aren't sick enough to need 24-hour CVVH. SLED, or sustained low efficiency daily dialysis, is very similar. Again, it's a dialysis stretched out, usually without fluid removal, but just the dialysis part to lower concentrations of solute, and this can be stretched out to 6 or 12 hours as needed. And then finally we have SCUF, which is slow continuous ultrafiltration. So this is ultrafiltration only with no dialysis, but it's stretched out over 24 hours. And this is usually used for patients who have pretty decent kidney function, but terrible fluid overload or heart failure, where the main need is for them to get rid of volume. Now a few words about middle molecule solutes, those with molecular weight 500 to 60,000. These are the ones that are less efficiently removed by diffusion than by convection, so CVVH and CVVHDF are better at removing them than dialysis is. Middle molecules make up some of the uremic toxins, of which there are about 130 identified, that are the substances that accumulate in renal failure and make people sick and make their physiologic processes not work well. Other potentially pathogenic middle molecules that have been shown to be cleared with the convective therapies include various cytokines, chemokines, myocardial depressant factors, complement activating factors, and things that could play a role in patients with sepsis and heart failure. So the factors that we take into consideration when deciding on the best method of RRT for a particular ICU patient include things like these. Hemodialysis efficiently removes fluid and small toxins, but may induce fluid and electrolyte shifts that are poorly tolerated by the very ill or hemodynamically unstable patient. So those are the ones for whom we choose CVVH. On the other hand, if the patient is extremely catabolic or hyperkalemic, the rapid removal of solute by dialysis may be needed because CVVH may not be able to keep up. And if middle molecule clearance is needed, CVVH or CVVHDF is the treatment of choice to remove those molecules that may play a role in producing disturbances seen in heart failure and sepsis. And finally, before we get too self-congratulatory about all the wonderful technological advances that allow us to treat these very ill patients with kidney injury, I just wanted to finish by showing what happens when we compare our very best human efforts, which would be CVVHDF, with the kidneys that we are born with. With CVVHDF, we use a combination of ultrafiltration, convection, and diffusion to clean the blood and to reduce its volume. With our own kidneys, we also use ultrafiltration and convection because plasma is filtered through the glomerular capillaries and enters the renal tubules. But once in the tubules, it can be further processed. It can have stuff added to it by secretion from the surrounding capillaries, or it can have stuff removed and reabsorbed from the capillaries and returned into the general circulation. The blood flow rates of CVVHDF are going to be around 100 to 200 mLs per minute, whereas our own kidneys have a blood flow rate of between 1,000 and 1,200. Dialysate flow rate for CVVHDF, this is the fluid that carries away all the stuff that diffuses out of the toxic plasma, is going to be around 20 to 50 liters per day, whereas with our own kidneys, we don't require any dialysate because any wastes that need to be excreted get processed into a small volume of urine and excreted that way. With CVVHDF, the principle is to remove large amounts of toxic uremic plasma by ultrafiltration, usually at a rate of 1 to 3 liters per hour or 24 to 70 liters per day, and then to replace it with toxin-free fluid at almost the same volume, around 24 to 70 liters per day. Our own kidneys, by comparison, ultrafilter at a rate of about 6 liters per hour or 144 liters per day. That's for a GFR of 100 mLs per minute. And the replacement of that filtrate is done not with large bags of fluid that have to be instilled, but rather with just reclaiming what's needed from the filtrate. In other words, we make our own replacement fluid simply by having the work of millions of tiny ATPase pumps in the renal tubules, pumping away to reabsorb fluid and electrolytes and return them to the circulation. Net fluid removal with CVVHDF usually runs anywhere between 0 and 4 liters per day, sometimes maybe a little bit more. Our own kidneys don't need to do quite that much net fluid removal usually. They usually process the urine into about 0.5 to 3 liters per day, but they can do more if they need to. Middle molecules, some of these uremic toxins and cytokines and stuff that are removed by CVVH are cleared at a rate of about 15 to 45 mLs per minute, whereas with our own kidneys, they simply take all the uremic toxins and anything else that needs to be removed and adjust them individually to whatever needs to be done. And finally, the logistics of the equipment for CVVHDF. The equipment is big, it's cumbersome, and it's very expensive, whereas our own kidneys work with a combined weight of 250 grams, and they do their work for free. So I hope that this has given you a helpful overview of the types of RRT that we can use in the ICU. And if you have any questions or comments, please feel free to email me at mlam@metrohealth.org. Thank you for listening.